I'm Dr. David Morwood, and welcome back to Your Health radio and television program. I am a board-certified plastic surgeon, and I am delighted to welcome as my next guest the illustrious Dr. Doug Sunde, plastic surgeon, board-certified plastic surgeon. Dr. Sunde, thanks very much for coming to the program.
Thanks, Dr. Morwood, for having me.
Dr. Sunde, we are going to talk about a very interesting topic today, something that I know you're very good at and that we both do, and there's a lot of in this county, and that's Mohs chemosurgery reconstruction. Now, the plastic surgeon doesn't actually do the Mohs procedure, but we're involved with the reconstruction. Isn't that right?
That's correct.
So who is it that does the Mohs chemosurgery or Mohs chemodermatology? I know there's a lot of different names to it. Who does the Mohs procedure?
There's a lot of different names. In this county, we have an expert Mohs surgeon named Dr. Richard Hambley. Dr. Hambley, typically Mohs surgeons are dermatologists, and what they do is they do an extra year of training. And the concept of Mohs surgery is for them to three-dimensionally remove the tumor and take out just the tumor cells and not any extra cells.
Okay, so that's typically for a skin cancer, right? So if someone has a cancer of their eyelid or their nose or their upper or lower lip, they might have a biopsy, right? And we want to explain to our audience exactly what a biopsy is. And then I want to talk about how that specially trained dermatologist, Dr. Hambley or Dr. Lowe, Dr. Jacob Lowe, will do Mohs chemosurgery or a Mohs procedure to remove that. Now, can you tell us a little bit more about how that's done?
Well, we'll start at the beginning for everybody. There's usually three main kinds of skin cancer. There's basal cell carcinoma. That's the most common kind. Squamous cell carcinoma, which is just a little bit more aggressive. And then there's melanoma, which is the most aggressive bad kind of skin cancer. And usually for either the basal cell carcinomas or the squamous cell carcinomas, we talk about a couple of different ways to treat them. One way is with radiation therapy. It avoids an operation, but the cure rate isn't quite as high, and it damages some of the surrounding tissue. It can be a great thing for some patients and not for others. And then there's Mohs surgery, where they excise the tumor, but in a very exact way. Dr. Hambley and Dr. Lowe both do that.
So it's almost like a frozen section going step by step, right? Like, don't they take some of the skin cancer and look at it immediately to tell whether they've got it all or not?
They do it in their office, and what they do is using frozen sections, but again in a very exacting way. They can map out and say there's tumor here, and so they can follow this, and they get to this edge and say that edge is clear. And then once they get it clear in a 360-degree, three-dimensional fashion, then they either fix it themselves, or they refer it to a plastic surgeon to be repaired.
Right. And Dr. Sunde, I should mention I've seen some excellent results that you've done, really wonderful reconstructions on, and I know that you do reconstructions not only that come from this county, but from other places. People come to you to have your reconstruction, which I think is just a real compliment to your skills. So let's talk a little bit more about the type of reconstruction that you might offer to a patient. Let's say they've had some of the skin removed from their nose, or they might have had full thickness tissue removed from their nose, or a full thickness portion of their eyelid removed because of the skin cancer can actually grow down deep. Isn't that correct?
That's correct, and I think one of the important things that our audience should know is that in some areas of the body, it's not critical if you take a little bit of normal tissue or not. So, for instance, on the back of my hand, if I took an extra millimeter or 1/16 of an inch or extra tissue just to get it all cleared out, it wouldn't matter. And in those cases, this Mohs surgery might be too much to do. But in areas of the face, when you don't have very much extra tissue, like on the tip of your nose, and your eyelid, on your cheek, taking an extra 1/16 of an inch or 32nd of an inch or 1/8 of an inch, all of a sudden starts to matter because these defects get pretty big.
So I've heard some people refer to Mohs chemosurgery, removing it that way, as cell-saving. It's a cell-saving procedure, and other people say it's done so every little cell that's cancerous can be removed. I think there's a number of different advantages to do that. So let's say you've got a patient in your office who's going to have Mohs chemosurgery. Now, how do you counsel them ahead of time about what they're going to need for reconstruction? I mean, do you talk to them about flaps and grafts and cartilage, and How do you go about educating them about what's to come?
I think it's a great question. I think it's really hard sometimes because one of the things that Mohs surgery taught us over the years is sometimes the skin cancer would look like just a little eraser head, and all of a sudden when they go microscopically remove it, it turns out to be as big as a quarter. And so sometimes the defects can be much larger than they appear to the naked eye. And so usually we talk about reconstructing things in terms of layers. So for instance, the nose has 3 layers, kind of like an Oreo cookie. It has a lining, it's got a structural central layer, which usually consists of cartilage, and then it's got an outside skin. And again, the eyelid has that same kind of 3-layered Oreo cookie phenomena where it has an inside pink mucosal layer. It's got cartilage in the middle. It's kind of interesting. Most people don't realize that there's cartilage in the eyelid, but that gives it some stiffness. And then it has an outside. And there's some muscle in there and things. But then we talk about, usually we talk about how are we going to reconstruct these or try and make them normal, because that's what plastic surgery is about, trying to take abnormal situations and trying to make them closer to normal.
Okay. Now, Dr. Sunde, we both do flaps, and I'd like you to talk about nasolabial flaps, and I'd like you to talk about forehead flaps, and then I'd like to talk about the difference between a flap and a graft. Like sometimes we'll actually take cartilage and skin from the ear, right, and transpose it to the nose. We call that a graft. So can you tell us about the difference between a graft and a flap, and then we'll talk about a nasolabial flap and a forehead flap.
Well, the grafts are, I think the most common way people think of grafts are skin grafts. And everybody's pretty familiar because if you burned your hand, then of course everybody would, you take a skin from a part of the body and put it on, and then because there's good, well-vascularized tissue that can nourish it, the graft can get a new blood supply and come alive. And it's a miracle.
Now, Dr. Sunde, let me interrupt for 1 second. One of the things I hear in my office all the time is a family member might come, say, with their husband who has a skin cancer, and the wife might say, hey, I'd like to get a tummy tuck, and can you use my skin to help reconstruct my husband's cheek, for example? And that's not a joke. I mean, is that possible to do?
It's unbelievably kind of the person, but unfortunately it's not possible because you would reject somebody else's tissue. And so, unless you're identical twins. But so like in a heart transplant, they're able to do that because they give them a lot of drugs to suppress the other person's. But for this, you need to use your own tissue. And so what we do for grafts is we can take skin grafts or cartilage grafts. Cartilage grafts most often come from the ear. We can take, there's some spare cartilage in your ear that we can use. And sometimes we can take 2 tissues together, skin and cartilage most commonly, and they call it a composite graft because it's 2 different layers together.
Right. So I think it's important to emphasize to our patients that a graft is tissue that we totally pick up from one part of the body, like the ear, or we might take a skin graft from the thigh, right? We totally separate it from the body, and we transplant it to go somewhere else, right? Like the eyelid or the cheek, etc.
Exactly. But the thing for a graft, the one thing we have to remember is it has to have an environment that can nourish it. It can't nourish itself. And so it has to have either some nice tissue with blood supply, or maybe if only the skin or cartilage is missing, it's got some nice tissue underneath it that it can get blood supply from, then it will work.
Right. So in surgery, we might do a bone graft for an orthopedic surgeon. We do cartilage grafts, skin grafts. We might do a tendon graft, etc. Now, tell us about a flap. What's the difference between a flap and a graft? Like, I know that you do an excellent forehead flap, and sometimes in my practice I do nasolabial flaps. Can you tell us about the difference between a flap and a graft?
A flap brings its own blood supply, and usually there's 2 ways to do that. So if there's not enough blood supply in the area, a flap can bring its own blood supply. One way to do it is leave it attached to the body. And so for years and years, since maybe 700 AD or something, they would bring a forehead flap straight up the top of your forehead and bring it down like a crane or like a tie and bring that tissue attached to your forehead still, right between the eyebrows, and use it to get under the nose. And you'd say, well, you can't leave it like that forever, of course. But again, the human body's so incredible that over a period of about 3 weeks, it can kind of grow into the area, and then you can go back and cut it, and it will be alive because it'll have brought the blood cells with it that grow into the surrounding areas. The same thing for a nasolabial flap, where you can take an area like this right along that crease so it's really hidden, bring it along, and then bring it up and leave it attached here where the blood vessel goes in. Bring it to the nose, let it sit for about 3 weeks, and then cut it, and you can bring that back, and it's a nice hidden scar there.
So we leave a little bridge of tissue with a vessel in it to give the tissue blood supply, right? To deliver the blood supply until it's happy living in its new little home, right?
Yeah, and it's unbelievable. You would think, how does it develop blood vessels into the surrounding tissue? But it just does, and again, it's just an incredible human body. And then there's a third kind of flap called a free flap, where we cut the tissue from one part of the body off, bring it to the new area, and then using a microscope, we hook up the artery, which brings the oxygenated blood to the tissue, and hook up a vein, which brings the oxygenated or deoxygenated blood away from the tissue so that the blood can circulate. And we don't do that very often for the facial defects, but often for other bigger defects.
Well, Dr. Sunde, I don't mind telling our audience that I'm fortunate enough to be able to work with you under the microscope, and there's very few surgeons that I've worked with who have the skill you do under the scope, and I think you're an asset to this community. Now, let's tell our viewers and our listeners why we'll sometimes, actually most of the time, do more than one operation, say, to do nasal reconstruction.
Well, for the nasal reconstruction, one of the concepts, as probably our audience knows by now, that you and I work together a lot, and really I've learned so much from you, but one of the great concepts early on is to get the tissue alive. So if we bring a graft or a flap or anything, if the tissue doesn't live, not only is it we've wasted the operation, we've wasted the tissue, it's very disappointing. And so the first and foremost thing is to get the tissue to the area and have it be alive. And then one of the things, once the tissue is alive, then we can go back and sculpt it and trim it and move it and try and get it just right to make it look as close as we can, although we can never get it perfect.
So that's why sometimes we tell our patients the first operation is just bringing the granite to the sculptor's workshop, isn't that right? We just want to get the tissue to where we want it to be, get it to live there and be happy. Then we can divide the bridge and then mold and shape and tailor. Isn't that right?
That's what you taught me. Bring the granite to the workshop. That's the first thing.
Well, Dr. Sunde, you're very gracious, and I appreciate you coming on the program. I know you're so good at this Mohs reconstruction. Now, let's talk about refinements to nasal reconstruction. We talked about bringing cartilage and skin from the nose. We talked about nasolabial flaps. We talked about forehead flaps. Now let's talk about those refinement steps. You told us that after you transpose a flap, you might wait 2 or 3 weeks before dividing it. And then what? How do you do those refinement procedures?
Well, I think it depends how big the defects are. If they're small defects, usually what we do is the person would have the skin cancer, go to see Dr. Lowe or Dr. Hambley, and they would have the operation, say, for instance, on a Monday. They would come to your or my office on Monday afternoon, and we would make a plan with them. How are we going to fix this? Can we do a graft? Do we need to bring... Is there not a good bed for the graft to take, and we have to bring in other tissue? And then what we would do is we would execute that plan the following day in their operation. And so the nice thing is it gives us time to look it over and make a plan. And then we would do the first operation the first day. For usually 3 or 4 weeks after we would move the big tissue, if it was a very big hole, then sometimes we go back and actually lift it up and try and trim it down a little bit to make it thinner, try and make it look more like a nose, make it more perfect. And then sometimes we put it back down and let it sit for about another 4 weeks, and then go back and divide it later. So those are all just little technical things that we do. But the big thing is, even with my best results, I like to see the patients back at about a year. And at that time, I always tell them my job is to tell them if there's anything more we can do for them to make it better. And it's their job to decide if they like it or if they'd like to do more.
Dr. Sunde, one of the things I like to tell my patients in the office is if they've had a skin cancer that's been growing certainly for 2 or 3 years before people can tell it's there, and then they have it removed, it might take us half that time, excuse me, or a third of that time to do the reconstruction. In other words, they can't judge the result right away. Isn't that true?
I think not only is it critical you can't judge the result right away, but I think the other thing is that we can continue to help make them better over time. As the swelling goes down, as the tissue settles down, as gravity takes its place. And sometimes we can even take the normal side and try and move that or lift it or do something to try and make that look more like the reconstructed side. So we can sometimes adjust both the reconstructed side to make it look more like the normal side. And for instance, if somebody's had a lot of aging and the skin looks much tighter on the cancer side because we've taken a lot of skin out, sometimes we would tighten the normal side to make it look more even and symmetrical.
Now, Dr. Sunde, you spoke about seeing them sometimes the same day they've had Mohs chemosurgery or the day after. Do you prefer to meet them or see them before their Mohs to take pictures and to talk to them, or do you just as soon meet them after the surgery, after the Mohs procedure?
I think one of the most important things for all patients is to understand, have information, and have realistic expectations. Those are really critical things for any patient, really for any operation they have. And so I like to meet them before. We talk about plans. We talk about how big we think it might be. And then a lot of times we look at photos and discuss how things might be for them. And it's a tough day for people because no one would like to see a defect on their face, but then we discuss how we're going to work through that.
So, Dr. Sunde, you raise a very important point, and I'm glad you're bringing it up, that with the removal of a skin cancer from the face, on the face, it brings up a lot of anxiety in people. I mean, the face is a social tool, and people want to look themselves, and they sometimes want to look even better than they did the day before they met you, of course. So how do you help allay, or how do you help to relieve some of their anxiety and their fears?
I think it's 100% people have anxiety. 100% of people are upset about it. Who wouldn't be, of course? So we talk about it. We tell them how we can fix the problem. And then I think for them to have an idea about how we're going to get to a better place, it just is going to take some time. And to tell them that, for instance, you and I are both experts in this. So I think it makes people feel better to know that they have expert surgeons taking care of them. We've got a lot of confidence in the Mohs surgeons. And so, and that we'll work through it together. I always tell the patients, almost really the bigger the defect they have, the better the friends we get to be. Because we do more together and we get to see each other, and it's a real process, and we get to know our patients well.
Dr. Sunde, again, I so appreciate you coming on the program, and I know you're really good at this type of reconstruction. We've only got about 60 seconds. Can we give out a website or a phone number if people have questions and they want to learn more about what you do for them if they're going to have Mohs chemosurgery?
I think that certainly the experts on Mohs surgery are Dr. Richard Hambley. He's in Monterey. Dr. Jacob Lowe, he's also in Monterey. Those are two people that we're fortunate to have in the community. And then in terms of reconstruction, they can either call you, Dr. Morwood, at 646-8661, or myself, Dr. Sunde, 372-0200. Or any board-certified plastic surgeon should be able to help with this kind of thing.
Well, Dr. Sunde, I appreciate your expertise, and I admire how hard you try for your patients. And I certainly appreciate you coming on the program. I hope you come again.
Thank you very much for having me.
I'm Dr. David Morwood, and I am a board-certified plastic surgeon. This is Your Health radio and television program. We're going to come right back after a very brief pause for a very good cause. Thanks very much for being here.
We'll be back with more of the Your Health radio and television program on News Talk AM 1240 KNRY, AMP's cable channel 24, and on the web at www.ampmedia.org.
Welcome back to Your Health radio and television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon, and we're going to do something a little bit different for this segment. I have another board-certified plastic surgeon, Dr. Doug Sunde, who is here with me, and we're going to talk about my recent trip to South America and his experience repairing cleft lips and cleft palates, and we're going to talk about how we go about repairing a cleft palate and some of the important issues regarding children who are born with a cleft lip and cleft palate. And once again, Dr. Doug Sunde, thanks for being here.
And Dr. Morwood, we thought we'd switch gears a little bit today because you're kind enough to ask everybody questions about what they do. But I thought everybody really would like to know what you've been doing. So where have you been? Can you tell the audience a little bit about where you've been the past couple of weeks?
Dr. Sunde, actually, I went with this program called Rotoplast. It stands for Rotary Plastic Surgery. I go somewhere about every year. One year I went 3 times, but that's too much because, you know, we're both in private practice. And I know it's something that you've done as well. You've been to a number of places in developing countries. And so the Rotary Club sends me somewhere, like Central America, South America, Southeast Asia, and we work with children who were born, children and babies who were born with cleft lips and cleft palates primarily.
So how does it work? Do you just how do you get a group of people together, and who goes?
Well, the Rotary Club of San Francisco is sort of like the sponsoring organization. It's like the big umbrella organization. And what they do is they get a co-sponsoring Rotary Club from somewhere in the country. For example, this last trip, I went to Colombia. I was there for about 2 weeks. We operated in this wonderful place called Pereira, which is not too far from Cali. So it was co-sponsored by a Rotary Club in Massachusetts. And you may know, I grew up in Vermont, and my dear sweet mom was from Massachusetts, and to hear that accent again from Boston and the middle of Massachusetts brought back some great memories. Anyway, wonderful people. So the program, basically, they get a co-sponsoring Rotary Club under the umbrella of the San Francisco Rotary Club. And then they coordinate with a Rotary Club in a developing country. For example, in Pereira, which is not too far from Cali. They've been to Medellin, and they've been to Cali, and we've been to Chile and Argentina and Venezuela and El Salvador, and I've been to South Vietnam and China. And Dr. Sunde, you've been to, is it Vietnam?
Right, but we'll concentrate a little more on this. So you've been on many trips, and it seems like you go at least once a year. How do you find time to do it?
Well, Dr. Sunde, you know, it's just something that I really love to do. I feel like I get as much out of it as I leave. It's very rewarding work, and I like to work with the kids, and I like to do cleft lip and cleft palate repair, and it just seems to be so rewarding that I just keep going back year after year.
I tell you, it's unbelievably generous of you to do, and you don't get paid for it, and it's all volunteer, so it's a pretty great thing. So can you tell the audience a little bit, like, what is, people talk about cleft lip and hair lip and cleft palate. Can you tell us, like, what those mean and what the difference is?
Okay, so I think that a cleft lip is pretty straightforward to most people. The lip is something that we can see. Plastic surgeons have kind of a fancy name for it. They call it the primary palate, but that's kind of getting confusing. Plastic surgeons call the primary palate anything anterior to something called the incisive foramina that holds the teeth and the lip, but that gets to be a little complicated. Typically, the cleft lip is what we see, and it has a split in it.
That's like a hair lip.
A hair lip, right. Or the palate is the roof of the mouth. Now, the roof of the mouth serves as the floor of the nose. That's the hard palate. That's that bony structure. And then posterior or behind that is the soft palate. That's the fleshy part that holds the uvula. If you look way in the back of your throat, way in the back of the mouth, you'll see that little it looks like a little flutter valve almost.
That's when you say, ah, right?
Right, so the doctor can see what's going on in the back of your throat. So they all have different functions, and they're all very important to repair. Now oftentimes I'm asked, well, do you have to have a cleft lip with a cleft palate? Can you have one or the other? They can come together. You can have a cleft lip alone. You can have a cleft palate alone. You can have a cleft of only the soft palate. You can have a cleft of the hard and soft palate together. It comes in all varieties and also severities. It's interesting to me that it varies, the incidence of clefts vary according to where it's found in the world. It's predominantly, I think, a multifactorial cause. Mm-hmm. It's found in the gene pool. And we do know there are some causes of cleft lip and palate. Like, for example, on day number 28, that's when the facial segments are designed to fuse. And, of course, that's before most women even know they're pregnant. It's day 28 in utero Most women don't even know they're pregnant, and those facial segments are designed to come together and fuse. If anything goes a little awry or if anything goes wrong, then a cleft can occur.
Do they have cleft lips and palates in the United States, or is it mostly in other countries?
Great question. So we know the most common incidence of cleft is found outside of Shanghai, China. 1 out of every 250 kids born outside of Shanghai, China has a cleft. In the western side of South America, it's 1 out of every 450 kids.
Wow.
In Caucasians in North America and Europe, it's about 1 out of every 1,200. Now, the African kids get a little bit of a break because it's found in only 1 out of 2,000 kids in Africa. So it seems to be genetically, it has its origins in genetics. But if we look at the incidence of clefts around the world every year, there's 250,000 babies born every year with a cleft. 250,000 babies. I mean, it's a huge public health problem.
So why do you end up going to those other countries? They don't know how to take care of them, or they won't take care of them, or?
Well, that's a great question. You know, they're overwhelmed by numbers. They're short on operative time. They're short on operating supplies. And, you know, I don't mind saying that training is different. Not every plastic surgeon in the United States goes through training to learn how to properly repair cleft lip or cleft palate. And in other countries, it's the same. And I think there's a relative shortage in many developing countries of plastic surgeons who know how and are familiar and comfortable with doing cleft lip and palate repairs. However, I do want to say that in almost every country we go to, there are some excellent plastic surgeons that we work with. We work together. They show us tips. We show them tips. And we work together. I don't want to give the impression that we go down and we say, hey, you know, move aside. The Americans are here. We're going to show you how to do it. We work with the people. They always assign terrific nurses to us, the anesthesiologists in other countries, and some of the surgeons work with us. The surgical techs scrub in, and we're happy to just work with the host country and kind of help them catch up. That's what it's all about.
So is it it's more teach a man to fish, or is it instead of give a man a fish?
Well, we try to teach. And another thing that we do is we try to raise the consciousness for the government and the health system in a place. Like, for example, in the country of Chile, I'm delighted to say and realize that Chile is taking over its own rotoplast program. In other words, they're getting to the point where they're going to do their own cleft lips and palates. They're at that point in development of the country. And part of that has been the programs like Interplast, Rotoplast, going down there and raising the consciousness of the government. Like, we've had receptions where the governor of the state would come and say to us, I didn't even realize that these children were born in my state and they didn't get care. You know, unfortunately, in a lot of developing countries, the kids with cleft lips and palates are sort of shunned. They never leave the farm. They're too self-conscious to go to school. They're sort of warehoused away. And they don't come out unless a program like ours comes around.
Well, we can all imagine, I think any human can imagine that if you had a big hole in your lip, that'd be horrible to be out. And how long does it take you in terms of an operation to really change a child's life and put that lip back together?
Well, to do the cleft lip repair and we try to do the nose at the same time, it's about an hour and a half.
So in an hour and a half, you can really turn somebody's life around for them.
Well, you know, we try to give them a shot at looking normal, and we do it successfully. And what amazes me is throughout the world, it's amazing to me, these mothers and fathers bring their kids in. I don't care if it's Ecuador or Venezuela or El Salvador or Vietnam or China. The parents just want to give their kids a fair shot.
What is the reaction like when the mother sees her baby with the lip repaired?
You know, it's Dr. Sunde, it's really part of the reason why I go on these trips, because sometimes in the recovery room, it's the first time they'll see their baby with a face that's anything like normal. They still have stitches in, and they might have a dressing on, but they see the signs that soon thereafter their baby is going to look pretty much like the other school kids or like the other kids or like their brothers and sisters. And it's really an overwhelming moment 100 times over.
It's exciting, huh?
Yeah, it is exciting, and it's rewarding. And this last trip to Colombia We did 150 operations. We were there about 2 weeks. And, of course, I was not the only other surgeon. We took 3 surgeons. One surgeon from Holland, there was another surgeon from New York City, and one from Washington State. And we had a team of about 20 nurses and doctors, and we took a couple pediatricians, et cetera. And on the first day there, we have clinic, and the Rotary Club there in the host city spreads the word. So they coordinate with San Francisco. So they spread the word, and they tell, I don't know how they get the word out, but they're great at it. They spread the word that on a certain day, at a certain time, in a certain town, the Rotary American team is coming. So if there's any village or town or in the city, if you have a baby or a child with an unrepaired cleft lip or palate, then come in. It's free.
The people don't have to pay.
It's free for them. We don't get paid. We just do it.
It's just all volunteer. And then if people wanted to give money to help this, where would they call for that?
Yeah, they can go to rotaplast.org. It's rotaplast.org. Or they can look on my website, drmorwood.com, drmorwood. There's another program that I've been with called Alliance for Smiles. They go to China. They're on the internet as well, allianceforsmiles.org. And I know that you did a lot of work with Interplast. That's based at Stanford and Palo Alto. And I think Interplast was one of the first programs to do this kind of work, wasn't it?
He's one of the first ones. But let me ask you one other thing, so that everyone can imagine the cleft lip and how that would change somebody's life. Is it as important to fix a palate? I mean, does it really matter, or is that like a secondary thing?
Well, see, that's a great question. The palate is the roof of the mouth, which serves as the floor of the nose.
So what's that do?
So there are a number of issues. If a child has a cleft of the hard and soft palate, there's a number of problems. First of all, because that valve, or that it's sort of a hammock, way in the back of the throat, can't stop the airflow, kids get what we call velopharyngeal incompetence. In other words, they can't direct the airflow coming out of the lungs, up the trachea, and they can't direct the airflow properly between the nose and the mouth. So what about that? If we back up a little bit, because they can't make that vacuum or that valve doesn't work, they're really slow eaters. If a mother has a baby without a cleft and it takes the baby, say, 20 minutes to finish a bottle, for their little brother born with a cleft palate, it might take him 2 hours. So in a developing country where they might be short on formula or milk and the mother doesn't have a lot of time, the baby often ends up underweight. Second, because they can't clear the eustachian tube, that little hole in the back of the throat, when you go up in a plane and you swallow hard or a very high elevator, you can't clear the ear, so they get ear infections. But primarily, their speech is poor.
So if they have a cleft palate, they can't speak normally.
Well, they can't say certain words like cookie or Coca-Cola or papa or tango because they can't direct the air properly between the nose and the mouth because that valve doesn't work properly.
So by fixing the cleft palate, not only do you keep them from getting fluid out their nose, and you let them eat more efficiently, but you also make it so they can speak more normally.
Right. The big goal, especially in this country or when we go on these trips, if we can fix a soft palate before the age of 9 months, then they have a great chance, a great shot at speaking normally because at about age 9 months to 14 months, that's when most babies start to use their hands and they want to get up and stand and possibly walk, and they start to speak. So if we can fix the palate at age 9 months, especially the soft palate, then that's a huge step forward.
Dr. Morwood, I think it's unbelievably generous of you to do it. I think you're a real expert at this. And by all your trips, you've had a huge amount of experience with this. And I think it just serves as a lesson. I gave a speech in front of the hospital a while ago and talking about all the great things that some of our hospital staff members do. But certainly you're an example to everybody in terms of taking time away from your business, time away from your life, and going and helping other people. It's a great thing, and you really should be recognized more for that.
Well, Dr. Sunde, I certainly appreciate you being so gracious, and thanks for being my host today for Your Health. I'm Dr. David Morwood. I'm a board-certified plastic surgeon, and that was sitting in as the host position, Dr. Doug Sunde, also a board-certified plastic surgeon. This is Your Health radio and television program. I hope you come back and view and listen soon. Please see us next week. Thank you.
You did a great job.
So, want to talk about your trip to Vietnam? Where'd you go?
I went to Ho Chi Minh City, to Saigon, and I think it was incredible. You know, for me, I'd never really been out of the U.S. much, and certainly never part of that world, so it was just incredible to see the people and see how kind they were and see how much the needs were.
I think it's amazing that was it Dr. Don Laub who got the idea for Interplast?
He started it. He thought it was a great idea, so they got an RV, and they went and they got a couple nurses and a couple doctors and an anesthesiologist and a pediatrician and got in the RV and drove to Mexico.
And they started doing cleft lips and palates.
They'd just show up in town and they'd say, like, we're here and we know how to do cleft lips and palates, and does anybody need one? We'll do it for free.
I heard this great story. I don't know if it's true or not, but I heard Don Laub and Jack Fisher and got an anesthesiologist, and they got a canoe and went down the Amazon and started repairing cleft lips and palates. I think that stuff's amazing.
There's some incredible stories. There was one story of a guy who got his cleft lip repaired in the middle of the night. They'd met an adult who had an unrepaired cleft lip when they were out that night. And they said, we can fix this for you. And they went, and after the evening was done, they went and fixed his cleft lip under local anesthesia.
Amazing. Wow.